I'm Richard Mala with the Long-Term Care Community Coalition. As many of you know, we are a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for elderly and adult disabled people in nursing homes, assisted living, and other adult care settings. Our major work has always been policy research and analysis and systemic advocacy based on that research and analysis. But more and more over the last 10 to 12 years or so, we've been doing public education. And for example, like today's program, which will be on falls, because the standards are often not very well implemented in the lives of residents, the protections and the rules about care and standards for care, I think it's really important for residents and families and ombudsmen and those working with residents and families to be informed about what care should look like and what residents' rights are. So we do more and more public education, excuse me. And then lastly, we're also home to 2 local long-term care ombudsman programs here in the Hudson Valley of New York, and I'm very proud and happy to be able to host them. Our website is www.nursinghome411.org. All materials, all resources are available for free to use and to share. Next slide, please. Today's webinar is on falls prevention, focusing on process, not people, to keep nursing home residents safe. For materials from today's webinar, again, please visit our website, nursinghome411.org/webinar-falls/. And I believe that has been posted, yes, in the chat as well by Haley. So our first speaker today is Sharon Banks-Tarr, and I'm really excited. I'm so excited to meet Sharon, and that came about because first Eric Goldwine on our staff had shared with us, with me and other staff people, a program that she was on. Sharon has a master's in nursing, and she's a legal nurse consultant certified. And she's also worked, I believe it was for 10 years, as a surveyor of healthcare facilities in the state of Maryland. And before, I don't know if it was before that, but for 20 years, she served as a U.S. Navy nurse. She was honorably discharged, but she has extensive experience as a staff nurse, medical surgical, orthopedics, respiratory intensive care, and hemodialysis. And she's just very smart. And I found her program that I attended or watched afterwards, after it was given, to be very informative and very accessible. And I'm so excited that she's here to talk about this issue. Following Sharon, we'll have another speaker, and that's Tabassum Mohibi. She is a policy intern with us, and she is a Master's of Public Health candidate at Columbia University. Interesting for us, and hopefully for Tabassum also, is that she is a hospitalist physician assistant. It's very rare that we get people who are actually doing practice. And she has experience working with hospitalized nursing home residents and individuals who are awaiting nursing home placement. So she's provided a really interesting perspective for us and for our work in the months that she's been with us so far. And without further ado, I'm going to pass it on to Sharon, and then from Sharon, we'll go to Tabassum, and from there, we'll go to Q&A. Thank you. Hi, Sharon.
Hello, thank you. I am very honored to be here. Just a little bit personal information about myself. I love reading and learning. I enjoy the beach. I enjoy reading, walking on the beach, and just watching the awesome nature of water meeting the sand. I really appreciate this opportunity to be here today. So I will start with the presentation, which is fall prevention, focusing on process, not people. Falls are never events, and they've been identified by the Centers for Medicare, Medicaid, and the Joint Commission as never events, meaning that there are things that happen in the healthcare setting that could have been avoided or prevented, thus the term never events. And in 2021, the Sentinel event data that was released for the first 6 months of 2020 identified that the number of sentinel events is still comparable to what it was several years ago. So as we move into the background, in 1996, JCAHO adopted a sentinel event policy to help healthcare organizations prevent falls by using the RCA2 tool. So root cause analysis and using this tool was intended to establish methodologies and techniques to prevent harm. In 1999, the Institute of Medicine published the To Err is Human and Crossing the Quality Chasm report, which provided new ways to look at medical errors. And at the time of that report, 98,000 patient deaths had occurred for the year as a result of what was identified as preventable medical error. And this report identified failures of the healthcare system that contributed to those errors. JCAHO's summary data covering 16,695 incidents from 1995 to June 30th of 2021 showed that 14,000 patients were affected by sentinel events. And again, this is so looking at 1999 and moving into June of 2021. In July of 2008, CMS classified falls with injuries as never events and made the decision that reimbursable payment would be denied. So a final ruling was implemented, and it was in Section 702. That final ruling required that all of the states and the District of Columbia implement non-payment policies for what were called provider preventable conditions, including healthcare acquired conditions and other provider preventable conditions. So addressing never events, between 2001 and 2008, the National Quality Forum published a list of 28 serious reportable events across all healthcare settings. And from 2010 to 2011, the Center for Disease Control and Prevention initiated the STEADY, or Stopping Elderly Accidents, Death, and Injuries project, again as a process improvement approach to addressing never or sentinel events. Now, when we look at the fall data, currently, never events are grouped into 7 categories, and those are surgical, product, device, patient protection, care management, environment, criminal, and radiology. In 2014 and again in 2020, the Office of the Inspector General produced reports that included nursing home potentially preventable sentinel event data using the harm scale broad categories of resident care falls, medication, and infection. Every year, at least 3 million older people are treated for fall injuries. Over 800,000 older people are hospitalized per year for fall injuries. Many falls do not cause injury, and of those that do, 1 in 5 falls causes serious injury such as broken bones or head injury. CMS cost projections for fall injuries for 2020 to 2021 were approximated at $14,056. So falls are the leading cause of fatal and non-fatal injuries in older adults across various acute and post-acute healthcare settings. And according to the CDC, home and recreational safety, 1 in 4 Americans who are 65 and older fall every year. Every 11 seconds, an older adult is treated in an emergency room for falls. Every 19 minutes, an older adult dies from a fall. Hundreds of thousands of patient falls occur in hospitals alone. The projected rate of falls and the deaths associated with those falls by 2030 is 7 deaths from falls every hour. So falls are serious and costly, and the CDC Home and Recreational Safety annual cost of falls projection for 2020 was $55 billion. When the focus of fall prevention improvement uses tools like the root cause analysis, then it is possible to identify the problem, the solutions, and individualize a realistic, measurable approach to reducing the risk of falls, and definitely falls with injury. So what are some fall risk factors? Lower body weakness, vitamin D deficiency, difficulty walking, balancing, dementia. The use of multiple medications at one time, whose side effects can produce unsteadiness of gait or walking, resulting in falls, polypharmacy. Vision problems, foot pain or poorly fitting foot gear, and general physical plant hazards, which include broken or uneven steps, flooring, throw rugs, poor lighting. So what can I do? Well, this goes back to process. The data from JCAHO, or the Joint Commission, has proven that the RCA, or risk analysis system, works. You can identify the problem, you can integrate discussion with residents, families, ombudsmen, nursing staff, yes, surveyors and advocates, to share decisions, to increase adherence to improved outcomes, and to identifying exactly what the approaches are and what the types of institutional corrections and support are needed to reduce falls. So what do I mean by that? Organization, management, work environment, team environment. There's a lot of moving parts when it comes to communication. And it's very important that not only are the falls themselves documented, that the data is aggregated, and then there are some joint communication discussions about how to approach those problems.
Hi, everyone. My name is Tabasa Mohibi. First of all, thank you so much, Sharon, for that very interesting and eye-opening presentation, just proving how important and life-altering fall prevention can be. So thank you. So in light of National Fall Prevention Awareness Week coming up next week, At LTCCC, we have been working on a fall and accident prevention fact sheet for residents and families. Some of the information in the fact sheet was already touched upon with Sharon, but I'll just go over a few additional topics, including common protocols for fall prevention, what to do after a fall occurs, no harm deficiency, and the Code of Federal Regulations pertinent to fall prevention, which are just standards applicable to all residents of nursing homes in the United States. So according to the Code of Federal Regulations, facilities are responsible to keep residents safe and promote quality of life by ensuring the environment is free from accident hazards as much as possible. And each resident receives adequate supervision and assistive devices like wheelchairs or walkers to prevent accidents or falls. And according to the State Operations Manual Appendix PP, which is a document from CMS that provides survey and certification guidance with detailed guidance for long-term care facilities in the appendix, it states that facilities are also required to implement comprehensive resident-centered fall prevention plans for each resident with high fall risk. And of course, all of this should be done in a manner that respects residents' rights to privacy, dignity, and self-determination. Next slide, please. So to prevent falls and accidents, facilities may commonly use evidence-based fall risk screening tools to identify fall risk and implement a fall reduction program to prevent future fall prevention. They may observe or frequently check on residents with high fall risk and address fall risk factors such as environmental hazards like wet floors and equipment in the hallways. They should be addressing lighting and staffing as well. And they should also be frequently reviewing medications that cause dizziness and provide fitted footwear and annual vision checks. Facilities may also implement bed alarms or position change alarms, which alert staff when residents have changed position or are getting out of bed. However, studies have shown that the benefit of these protocols is not proven, and the alarm should actually not be used as a fall prevention tactic, as they only really notify staff when the fall has already occurred. And physical restraints should also be avoided as a fall prevention approach, and fall risk alone for residents does not warrant the use of restraints whatsoever. And there's actually evidence that restraints will reduce, there's actually no evidence that restraints will reduce or prevent falls, and they have a high risk of contributing to serious injury. However, recent research on fall prevention that should be considered when facilities are implementing their fall prevention plans includes research on upgraded lighting that has higher intensity during the day and lower intensity at night has shown to decrease the fall rate by 43% in 2 nursing homes. And a 2017 study showed that the implementation of a fall risk and intervention tool in 1 nursing home reduced the fall rate by 36%. And another study showed that the number of active medications was the most significant feature associated with fall risk. So really reviewing and re-reviewing resident medications is extremely important. This is a widely used 8-step response to resident falls that was developed by the Agency for Healthcare Research and Quality. So first, facilities should evaluate and monitor residents for 72 hours to ensure there are no changes in the mental status or overall conditions for residents. Then they should investigate why the fall happened in the first place and document why it occurred and what happened and who was there. The provider should also be always alerted so they can also perform a complete assessment and implement any interventions or decide whether or not the resident needs to be sent to the ED for further evaluation or oftentimes imaging. And finally, a resident-centered care plan should always be developed and monitored. Unfortunately, not all nursing homes follow fall prevention plans or respond appropriately, which can be extremely dangerous. And LTCCC publishes an elder justice newsletter where health violations cited as no harm are exposed. And most health violations are actually cited as no harm, but result in no fine or penalty to the facility whatsoever. But in many cases, these violations are actually harmful to residents. So this newsletter seeks to shed light on these violations and hold nursing homes accountable. So the citation I wanted to discuss is from a newsletter published earlier this year, which you can read using the link at the bottom of the page or in the chat. And this nursing home facility from Vermont failed to review and revise 2 residents' fall prevention care plans, leading to multiple preventable falls. And despite the multiple falls, the violation was still cited as no harm. And the facility's neglect led to a resident falling 7 times in 3 months without any new measures or protocols implemented during that time. And another resident fell 6 times in 8 weeks without any fall prevention measures taken. And the emergency room evaluation wasn't done until a fall led to a head injury and pain in multiple areas. So it's really important to note that this pain and injury could have easily been avoided if a comprehensive care plan was implemented before and after the very first fall. And also, as I mentioned earlier, resident-centered care plans are required under the Code of Federal Regulations to keep residents safe and promote their quality of life. Thank you.
Sharon and Tabassum, thank you both. That was really fantastic and so interesting. And as Tabassum said, we have materials on our website around this, so please do visit the website. Without further ado, we're going to go to questions. So please, if you have questions for Sharon or Tabassum, we would welcome them. There are a couple that came in, one from an anonymous attendee. Is each nursing home required to report the number of falls that have occurred in the facility? That information would be helpful when selecting a nursing home. I don't know if you want to answer that, Sharon, or if not, I can.
Well, I can say that by and large, each facility is required to keep track of falls that occur. They are not necessarily required to report them except to the agencies that track the data and try to help with solutions and figuring out how to approach the problems. There will be, from the state survey, the CMS 2567, that report is always available. And if it's not readily available, it can be requested to help make those decisions.
Thanks. Thanks very much. Any other questions for our speakers?
If I could,
yes.
step in. This is
Thanks,
Eric Goldwine, LTCCC's Policy and Communications Director. Thanks for the presentations to you both. We spoke a couple months ago about the right to make mistakes and how there's residents have the right to make mistakes, have the right to take risks, and maybe put themselves in situations where they might be more susceptible to falls. Sharon, can you talk more about why that is the case and how we can protect a nursing home residents' rights and the rights to dignity, the right to make mistakes, while also striking a balance and minimizing the risk of a serious injury?
Yes, that's where, when we talk about what can we do, the resident has the right to make decisions, even if they are bad ones. And sometimes it has to do with mentation. If you are at early stages of Alzheimer's or dementia, or if you're an independent person and you've always been, and it's hard for you to put on a call light or wait for someone to come and help you do something that you believe that you can do. So it's truly a partnership in order to not infringe upon resident rights to make their own decisions. It's a balance.
Are there any situations you can think of in your experiences where that's come up and you have tried to make that safer environment, or any tensions there?
Yes, it comes up often because, again, this is not an easy solution. It's not like, okay, we will do this, this, and this will always be done, and this will always be adhered to. Each person is different. Each person's level of independence, or the desired level of independence, is different. So from a surveyor perspective, for instance, I always looked for balance. Where was that family meeting? Where was the team meeting with the doctors and staff? Sometimes we did, as regulators, we would see where those the safety mats were on the floor, on the bed, because it at least alerted staff that something was going to happen. So Mr. Smith is getting out of bed. He's already fallen once. So he's had that opportunity to make the bad decision. Now let's support his independence while attempting to prevent the fall, or at least the fall with injury.
Thanks. We actually have a number of questions, unless Eric, you got any other follow-up?
No, that was good. That was really
Okay.
helpful. Thanks.
Sure. Yeah. So from Kathy Elias, from my own experience in a nursing home, the protocol, quote unquote, regular exercise translates into physical therapy, which has to be approved by PT. And if it is, lasts a short period of time due to Medicare, Medicaid coverage restrictions. I observed taking a wheelchair away from a resident's chair side and ultimately debilitating the resident's physical condition. I had a Medicaid insurer call it disability for convenience of staff. It's quite insidious. How does a family deal with it? With that, excuse me.
Again, this is an excellent scenario, and it's something that I personally experienced from the incident report perspective. It still goes back to when I was doing my research. It was about I'll put myself in the place of being the family member. So what have I observed as it relates to physical therapy and helping my family member to remain independent? What is the financial restriction in terms of how long physical therapy lasts, or how long the actual treatment regimen that's been put into place for that person lasts? Once this information is shared or communicated with the staff, then is where the team and the organizational structure comes into play. So what's the question? And how does my family member deal with their wheelchair being taken away? So we look at the problem and then explain or share information so that the intent of retaining independence is still honored, while decreasing the possibility of fall with injury. It sounds convoluted as I'm saying it, but in a short period of time, if you look at restrictions and you look at physical condition, this is where, if the staff and the family are not communicating, if observations are not shared, then that right decision for that resident is more difficult to reach.
Interesting. Thank you. Janine Ferrari has a question. Are falls held against for-profit facilities? Some facilities try to downplay falls, blaming them on the resident. Is this because it's their fault? Is this because if it's their fault, the facility can be penalized? So I can repeat. Yeah, I'm
So
sorry.
again, we look at care is patient-centered. And even though cost and money is always a factor, I would not say that facilities downplay falls. I would say they're trying to manage the information. And blaming, again, we talk about residents' rights. I have the right to get up and I have the right to fall. Now, you don't have the right to necessarily just let me fall haphazardly and hurt myself, but there's a balance that must be struck. And if there's not documentation that supports the slide I go back to is what can I do? If you don't involve the team, the family, then it gets to the point where the facility can feel penalized, the family can feel ignored, and so can the resident. But if the team is working together, then what are the factors that are causing the resident to be at risk for falling? It's balance.
Thank you. Very interesting. Thomas Kutris, I hope I'm pronouncing your name correctly. Should family members be contacted immediately when a resident fall, whether or not injury occurs?
According to regulatory guidance, the answer is yes. According to communication with family, the answer is yes.
Thank you. Virginia Collins asked, are families automatically notified when a fall occurs? What are the family's rights? So I think you answered the first part of that, but maybe in terms of families' rights in that situation, Sharon.
Again, it's balance. It's home. Nursing homes are homes. They're not confinement centers. So anything that happens in the home, the family member that has the power of attorney is and should be contacted when there are changes in the care or in the situation that involves that family's health, well-being, and safety. So when they view them as fall prevention measures, is that a physical restraint when it's let me see, side rails? There's guidance, and then there's something that's called common sense, but I learned long ago in nursing school, common sense is not less necessarily common to all of us. So side rails in and of themselves are considered to be physical restraints unless there is documentation as to why they are not. And even if they are not, there still must be, according to regulatory guidance, documentation about when they're used, why they're used, and what is the continued need for that use.
Thank you. Kivalina Lawrence asked, we have a resident with severe Alzheimer's whose doctor states she is a major fall risk and at serious risk of fatal injury if she hits her head again. She simply does not remember she cannot stand or walk independently. Facility continues to state, quote unquote, right to fall, despite doctor and family requesting some form of intervention. How can we advocate in that scenario?
So this is where the team planning conference comes in, and we're looking at someone who has severe Alzheimer's. So based on the nature of their, or the extent of their Alzheimer's, what stage are they in? So if this person can't remember from 1 minute to the next, then what's the plan of care that's specific to this person that still respects their rights and also prevents the fall? This is where that risk cause analysis comes in. By no means is this easy to do. And I don't want to sound cavalier, but for me, this is one of those patient care conferences, and you're talking about all the risk, you're talking about the strategies, and then you're talking about what can we do for intervention. And a lot of times in the memory care units, this is where those those mats that alarm as the resident is getting out of bed, the mats that are on the floor that alarm, but you're really documenting what is happening and why this is helping this individual not to fall. But I don't mean to imply that it's a cookie cutter or should be a cookie cutter response.
Thanks. Very interesting. Thank you. So Sharon Wallace asked, what can we do as residents in nursing homes protect ourselves from falls? Right now, I'm in a wheelchair, and the times I have to leave my room, the hallway is congested and I can't get the other people to move. Then I end up getting pushed into equipment or other people. I am rammed into a wall or door jam multiple times a day, and I'm being blamed. I can't move my wheelchair on my own. I have severe pain in my right foot for all the times it is being smashed into something, and my shoulders are squeezed tightly when I'm put into the Hoyer to get into the wheelchair.
So this is where my recommendation would be call for a nursing care planning conference. And in that conference, you're sharing this information. I don't, again, I'm not trying to, it's process, it's not people. And these people who are, they're in the congested hallways, meaning staff. The equipment and the door jams, these are things that you can get caught up in the course of the day and just kind of work your way around things. And you lose a sensitivity to an open corridor that would allow a wheelchair to move safely and navigate through those areas. The other piece of it too is life safety in terms of hallways being clear enough for exit in the event that there was an emergency. So short answer, a planning care conference, and all of the key players in terms of what can I do are brought into the conversation so that the care plan ends up actually reminding staff that hallway should be clear. And we should assign somebody, maybe it's we bring maintenance into the mix, and maintenance comes through periodically and make sure that wheelchairs and those sorts of things are not in the way. I don't mean to infer that different parts of the organization should be part of the solution, but the solution only occurs if that root cause analysis approach is applied to it, and not blaming you for being in the way.
Very interesting. Thank you so much. Pat Jennings asked, please discuss the issue of A, nursing home supervision, and B, short staffing related to fall with injuries when staff deliver care less than required by care plan. For example, 2-person transfer, but only done with 1 staff and results in fall during, I think she meant to say resident transfer.
Again, my first thought, and again, I'm looking at it from processes and from going into facilities as a surveyor, it was sometimes surprising to call various people together to have them various staff together to ask them to explain, here's an incident, or this is something that's happened, or I've spoken to a resident, I've conducted an interview. Please help me understand how this has happened, or how is this continuing to happen. The short answer is it needs to be a conference that has all of the people who are involved in being responsible for correcting the problem to be present. And just, I know that you might have already done that, but it's time to, it's possibly even talking to your doctor about it, but that planning conference has to happen so that all the key players that are involved in solving this problem can sit down and come to the conclusion of what can we do to make this not be an issue. Now, of course, short staffing is in the news, and staffing is being addressed in various ways, but there are still some other things that can be done in terms of two-person transfers.
Thank you. I would just quickly add, we have actually some excellent materials on our website regarding care planning and resident assessments. There's fact sheets and as well as forms that you can use so that you come prepared. Because I know, as someone who's been, of course, a patient myself over the years, that when you're at a meeting with your care professionals, you don't necessarily remember everything that you need to talk about with them or all the priorities. And this way you can, write them down in a way that's organized and have that prepared to, for those meetings so that you can hopefully discuss those issues. Thank you. Joan Bass has a question. Do nursing homes provide workshops for family members and or patients regarding falls and fall prevention?
The short answer is yes, they do. The longer answer is that's a question that I would have to present to that facility. And if they did not, then ask about it or offer that as a suggestion for something that you think should be considered, something that they should be doing.
This would be a nice idea for a family council or a resident council to also, if they wanted to propose to the nursing home, is to ask for a workshop like that. Kay, who's an ombudsman, said, can an ombudsman in their residents' rights program bring up the team effort and strategies to help residents from falls?
Absolutely. From my training, that was one of those, again, how can I help? It's that wide scope of family, residents, ombudsman, nursing staff, administrators. So absolutely, yes.
Yeah, it's a good question. Barry Bertel asked, what can or should families do when they are not notified by the nursing home when a resident falls? So they haven't been notified, like they learn about their resident fall subsequently.
Oftentimes for me, the first question is, who's the POA, power of attorney, the medical power of attorney? Sometimes when I've investigated complaints about family not being notified, the medical power of attorney was notified, or someone else who wanted to be notified, the staff did not have that authority to notify. You can call, but as far as who we notify, who's the medical power of attorney? And then that person shares that information amongst the other family members. If that's still a question, then again, it's bringing it up to the administrative staff.
Yeah.
There's a disconnect in communication. I'd like to know how we can fix it.
And this is something that an ombudsman could potentially help you with as well. Sharon Wallace actually has more of a comment, I think, than a question. The side rails on my bed keep falling down. They just don't stay up. The past couple of nights, I somehow push myself with my hands onto the bed to prevent the rest of my body being on the floor. I had to wait 40 minutes just for an aide to come to my room, and she only came in to turn off maybe a call bell or the light. So I had to wait again for somebody else to come back. I had my last care plan meeting last week, and the social worker head nurse didn't want to hear about it. So it's not really a question, but I don't know if you have any comments.
Activating the ombudsman. Because oftentimes the ombudsman is that communicator to help, as you know, ombudsman is Dutch for advocate, and that advocacy works very well when it's deployed or used.
Thanks. Anonymous attendee asked, if a facility decides to keep doors open to a backyard area if the weather dictates, this is a dementia facility and the facility has made the decision due to patients' rights. There is no oversight. Some residents are in a wheelchair and others are mobile but not steady. It's not really a question, it's more, I think, of a statement, but
Well, but I can also see the question in it.
Yeah.
Again, when I've investigated these kinds of things, oftentimes it has been the ombudsman that's been able to be the transitional communication person, because technically in a facility that is designated as dementia, doors should not be open so that elopement can occur. Because again, we get into another sentinel event, the possibility of death or injury. So if there's no oversight, the door is open and any resident who makes that decision to leave can do that. If you've already tried communicating with the staff, then again, I would recommend talking to the ombudsman.
thanks. Pat Jennings asked, from your surveyor's role experience, what constitutes potential and actual harm related to process to address falls?
So what constitutes potential harm? CMS and JCAHO have given the definitions for what constitutes potential or actual harm, and that's what I would look for. So for instance, falls is there's a potential for harm. Therefore, what is the facility's process? In fact, that's one of the things we look for. We ask about falls, we ask about meals, we ask about things that are in that realm of potential actual harm. And what do we do to address it? We look at the things that have been talked about so far: the care planning, the doctor's orders or practitioner's orders, the follow through of those orders, and the communication in those care planning meetings and in the resident and family council meetings.
Thank
So
you.
we look for process.
Thanks. Our last question, I believe, is from Gilbert Sabater. He just wanted to know if you meant proxy when you say POA.
I can only say what I've learned legally. So for me, I would look for who has power of attorney. There's medical power of attorney, there's financial power of attorney, and sometimes family or a non-family member has both medical and financial power of attorney. Proxy is a term, and I understand it, but legally speaking, the legal requirement is for a power of attorney.
Thank you. Barry Bertel asked the question, who's responsible when a resident falls and nobody is notified, including family, the power of attorney, or the healthcare proxy?
I think it's a self-answering question. Who is responsible? The facility at which the fall has occurred.
Yeah, I think so too. Thank you. Thanks everyone for your questions. Sharon, of course, thanks so much for your wonderful input. I am going to turn it over, I think, to Eric Goldwine, who has a few things to talk about.
On mute. I'm just gonna give a quick talk about staffing, and then we're gonna share a few other resources. Staffing, as you probably suspect, but has actually been proven in research, is correlated with fall prevention. So as I'm just going on from current slide. So there's a 2012 study in the Journal of the American Geriatric Society And the finding was that for newly admitted nursing home residents, nursing homes with higher CNA staffing had a lower fall rate. So in other words, more staffing, better staffing, fewer falls, better resident care. So I'm just going to quickly go over something we focused in our Q1 2022 staffing report that came out a few weeks ago, or we published this report a few weeks ago, and we focused this on nursing home staffing turnover, which is a key indicator of staffing. Higher turnover tends to mean worse results for nursing home residents. The average nursing home turns over more than half of its nursing staff within a year. And the same goes for RN staff. And that's just among the nursing homes that are reporting the data. What we find troublingly is that 17.7 nursing homes either submitted data that did not meet the criteria required to calculate turnover, or did not meet staffing, or did not submit staffing data. So why is this a problem? Higher nursing staff turnover leads to, or is associated with all sorts of negative results, including infection control, including lower ratings. I could not find anything immediately on turnover and falls, but I could. There's reason to believe that a nursing home staff that doesn't have consistency in its CNAs, or doesn't have good retention, might have staff that doesn't know its residents as well as it should, and that could lead to worse fall outcomes. Now, before we wrap up, I just want to share with you that you can find nursing home staff data online. So if you go to Care Compare, and I know some of you have searched for your nursing home ratings on Care Compare, but if you go to this website and find your nursing home and click on View Staffing Information, you can scroll, a window will pop up, and you can look at a nursing home's staffing turnover rates. You can look at the nursing home's weekend staffing levels and how that compares to the state averages and to the national averages. And I guess the grander point here is we sometimes will share a number that nursing home averages, say, 3 hours per resident day, which is below 4.1. But that number only tells part of the story. What we also want to know is what's going on with each position. What's going on weekends? Is it even lower on weekends when residents require the same level of care? Is a nursing home turning over a lot of its staff? So this new data, which is available on Care Compare and also available on our staffing report, can help you see the larger picture in terms of staffing ratios for an individual nursing home or for nursing homes in your area. So this is just an example of what our spreadsheets over at Nursing Home 411 will look like. You can see that, for example, I know this is small font here, but the top nursing home here is Holly, not the top in terms of performance, but the top in terms of where it is on this list, is the Holly Patterson Extended Care Facility. And that nursing home has a 28.8% turnover rate, meaning that 28.8% of the nursing staff was turned over within 12 months. And you can also see what's going on the weekend. So that nursing home had 2.5 HPRD on weekend staffing. So I'm going to leave that there. And then, Richard, we're going to just give a little plug for some of our future programs and for some of our upcoming programs. And I'm going to share the other PowerPoint. Right. You bear with me. So, yeah, so next month, we are excited to welcome Dr. Jonathan Evans for the October 18th, 1 p.m. Tuesday. We're always we're most of the time third Tuesday of the month. This month was an exception. And he will discuss what good care looks like for people living with dementia. He has all sorts of experience working with nursing home residents. And he comes with I was on the phone with him a few weeks ago. He has some incredible observation and insights and experiences and stories that he'll share. I know the title is "What Does Good Care Look Like?" but we'll also get into what does bad care look like. So we'll see both ends of the spectrum, and you can register for that at the bit.ly link, which we'll share in the chat. That is bit.ly/webinar-dementia. We encourage you to sign up, tell your colleagues, tell other advocates about the program. You'll be sure to benefit from it. Just a little side note. My very first day with the Long-Term Care Community Coalition, I was privileged to hear Dr. Evans speak this was actually at our 2019 symposium, and he really opened my eyes to a lot of the issues facing residents in terms of antipsychotic drugging and dementia care. And this is a big one here. So we have our annual reception coming up in just less than a couple months, on November 9th at 6 p.m. It's going to be a great event. We're going to be honoring Richard Gottfried, and we will also have food, refreshments, and a special performance from Bridget St. John. You might know her personally, or you might remember her performance at last year's online event. It was she had a mini concert through Zoom, but this one is going to be in person, and I'm excited about every part of the event, but I'm personally most excited about that musical performance. And you can look up the event and buy a ticket at ltccc13.eventbrite.com. And we also welcome sponsors and advertisers, and any way you want to get involved in this event. As a reminder, program materials from today's program will be on nursinghome411.org/webinar-falls. We already have the PowerPoint up, but we'll also have video up later in the week. You also get an email. It'll say it's from Sarah, but it's sent automatically through Zoom. That'll confirm your attendance and also include the link to the recording. And this page includes a fact sheet on falls and accident prevention, which Tabassum went over during this program. And again, we would love to see you at LTCCC 13, just a couple months away. It'd be a good chance to meet other advocates, to meet us, and to listen to a really fun musical performance. So, Richard, any final words before we close out?
No, just thanks to Sharon, thanks to Tabassum for really just such an interesting and informative presentations and Q&A. Really, Sharon, appreciate glad to get to work with you and to meet you, and appreciate your thoughtful and wide-ranging approach, or wide-ranging background, I should say, and how that translates into your approach to these issues. It's really terrific to see, and we appreciate it. Thank you, everyone. Thanks everyone for joining us. Of course, hope to see you next month. Bye-bye now.